get you? Well, that's about it. Thank you. No, how it over? What's important? That's why I check. Yes. Why Microsoft is 2024. This is I paid by years, and I have been always there. The latest one. Yes, one of the Yes. Do you want to check? Working? Perfect. Okay, great. No, thank you. Be able to see. Internamente, assim, olhando pelas cozinhas lá, sai do não, também, sai a porta também mesmo. Agora, fala, sai também, é bom, porque não sabe ninguém. Okay.
Bom dia a todos e a todas, como agora temos que aprender isto, né?
Ladies and gentlemen,
Bom,
well,
para quem não me conhece,
for
meu
those who
nome é
don't know me,
Dalpós,
I
sou
am
professor
Adar
titular
Koch.
aqui do
I am
Instituto
a professor here at the
e,
Institute,
desde
and
sexta-feira,
since
diretor da
Friday,
casa.
director of this institute.
Então, seguindo a
So,
programação
following the agenda
da semana de recepção
of
aos
this
novos
week
alunos
of
do programa de pós-graduação,
welcoming the
mestrado,
new
doutorado,
postgraduate and PhD students.
Obrigado. Vamos ter hoje
We will have today
uma experiência, mas
an experience, not an
de
experience,
tradução simultânea,
we will
né?
have
Então,
simultaneous
estamos
translation,
ajustando
and
algumas
we are
coisas,
adjusting some
YouTube,
details,
transmissão,
YouTube
não
and
sei o quê,
transmission,
vamos
broadcasting.
aprender isso.
So we will learn how to
Mas
do
para
this,
benefício de todo
but
mundo, eu vou falar em
for the
português
benefit of
e
everybody, I'm going
depois
to
a
speak in
gente
Portuguese, and then
acho que é mais fácil.
I think it will be easier. So,
Então, seguindo a programação da semana de
following
recepção aos novos alunos,
week of welcoming our
vamos ter hoje a
students, we
aula
will have
inaugural
today our
do programa acadêmico
inaugural
deste ano, né?
class
Eu
for the
agradeço a
academic
presença
year. I thank you
dos
very much
colegas,
for
da
all of
diretora
you being
Cláudia
here, the
Lopes,
director
minha
Cláudia
professora
Lopes,
titular
my
Roseli
professor
Sicheri,
Roseli
colegas
Sicheri,
da
colleagues
engenharia,
from
de
engineering
pesquisa, meu chefe de
department,
departamento,
research, and Fabiano,
outros colegas
and other
professores, o
colleagues,
Paulo,
professors,
Nadanovski,
Paulo,
Marilena,
Marilena.
creio que só.
I believe that's it.
E
And
vamos ter hoje,
we will have today,
como parte do
as
programa
part of our
de
program,
recepção dos alunos,
welcoming our
da semana
students
de recepção,
in
mas também
this week of
que é o
reception, and
programa
also
CapsPrint,
a CapPrint
que é um
program
programa,
that
um
is a
projeto
project
de internacionalização ao qual a universidade
internationalizing
concorreu junto à
the
CAPES,
university,
um
and we
programa
were part together with CAPES,
que
with a
projeto que
program, with a
incluía
project
muitas
that included
unidades.
many
O projeto do
units.
Instituto
A project of our institute
envolve os
involves
Objetivos de Desenvolvimento do Milênio e a
the
saúde coletiva, né?
SDGs and
E a
collective
gente,
health,
obviamente,
and
a
of
pandemia
course, the pandemic
prejudicou o andamento desse projeto em
hindered the
geral,
development of this project
que o
in
programa
general,
foi
and this program, of course, was
estendido, né, até
postponed and
2024,
extended
para
until
terminar em
2024. It should
2022,
have ended in
e
2022.
2021 praticamente não tivemos nada.
We practically didn't do anything
Inclusive,
because of
tivemos
the
que
pandemic,
quase que
and we
resgatar
had to
alunos
almost
de doutorado
rescue some
sanduíche que estavam
students
no
from
exterior
other
e
parts
que
of
tiveram
the
muita
world that
dificuldade de
were
retornar
abroad and had a lot of
logo no início
difficulty
da
to come
pandemia.
back to Brazil at the beginning of the
Então,
pandemic
essa atividade
because of the isolation, and
pertence a esse projeto, é
this
financiada por esse
this
projeto, né?
project is being
E
funded
também
by
faz
this,
parte,
and is
digamos,
part
anuncia uma
announces
série de
a
atividades que nós
number
vamos ter ao
of
longo desse ano,
activities that we will have during this year,
comemorando 50
celebrating
anos,
50 years,
professor Eliseu, coordenador
Professor
adjunto da pós-graduação,
Eliseu,
comemorando 50 anos da
celebrating
pós-graduação do
50 years
Instituto,
of past graduation of
e
the
algumas outras
Institute,
atividades,
and
alguns
some other activities,
comemorativo
some
nesse ano.
other
30
celebrations,
anos
30 years
do
of,
Núcleo de Estudos
the
de
study group of
Biologia e
biology
Nutrição,
and nutrition.
20 anos
20 years we are celebrating.
do outro, não, 20 anos do programa do Núcleo, 30 anos,
30
20
years
anos
and 20 years
do outro programa. Enfim,
of
tem algumas
another program.
atividades que
So
nós
we have
estamos
several
juntando
activities
esse
and we're
ano.
joining together this year.
Estamos, assim, essas datas
And
redondas
these
sempre é
dates
legal de
are
comemorar, é
always very nice
importante, é
to
uma marca,
celebrate.
né?
It's
Então
a
estamos fazendo
brand,
isso.
it's
E
important.
vamos
That's why we're
trazer,
doing this. And
eu
we're going to
espero, uma
have, we
série
expect
de
a number
pesquisadores
of
de universidades
researchers
estrangeiras
from foreign
nesse tipo de atividade, que
universities in
inclui
this type
uma
of activity,
conferência
include
para
a
alunos,
conference for
professores,
students,
pesquisadores,
professors,
convidados de fora,
researchers, and guests
transmitida via YouTube,
being transmitted by YouTube
com tradução simultânea,
with
gravada,
simultaneous
vai fazer parte do nosso
translation that's being
acervo
recorded. It's
aqui
going to be part
dessa
of the
comemoração.
collection
E
of our
atividades relativas à
and
presença do
activities that
pesquisador,
have to
que é o
do with
desenvolvimento de
activity
projeto
researchers,
colaborativo,
development of the project, cooperation,
elaboração de um programa
and also
de
a
trocas,
program of
ida de alunos,
exchange
professores, a vinda
of
de alunos,
going
professores
and coming
da
of
universidade.
students and professors of the
Sano, vice-diretor do
university.
Instituto.
Son,
Bom
the
dia.
vice director of our
Então,
institute,
dando início ao
and
programa,
starting our program,
a conferência, né? Nós convidamos
we have
para essa
invited
primeira
for this
atividade
first activity
a Adriana Castelli.
Andrea
é uma economista da saúde
She is
italiana,
economist,
formada na
Italian.
Universidade de
Adriana
Bocconi,
Castelli, she
com
is
10 em 10, ou lá,
10
101
and
e
10,
101
or
lá, né?
101.
Enfim, que corresponde, a
That
gente não tem mais
corresponds. We
isso,
don't
mas é
have this,
uma
but
laura
it's
importante.
very
E
important
fez seu mestrado e doutorado na Universidade de York, onde ela se
from the
transformou em
University of
pesquisadora.
York, where she
né? Então,
became a
pesquisadora
researcher,
sênior.
a senior
E vem
researcher.
trabalhando, quem
Adriana
estiver
Castelli, and
interessado
she's been working
em
for those
conhecer
who
mais
are
o
interested of
trabalho
knowing
da
her
Adriana, vem
work.
trabalhando com
We've been
análise
working with
de desempenho,
analysis of
produtividade e
development,
resultados
productivity, and results
do sistema de saúde inglês,
of
NHS,
English
que
health
nos interessa
system,
muito, por muitas
NHS.
razões.
That
Né?
interests us a
Seja
lot for many
porque, diz os
reasons.
jornais, foi inspiração do
Because the
nosso SUS,
newspaper
não é
says
bem
it was an
verdade,
inspiration
mas
of our SUS.
certamente foi
It's not a fact,
um dos
but
elementos
certainly it's one of
que,
the
quando
reasons
discutimos
that
a
when we
conformação
discussed
do Sistema Único de Saúde, ao menos aqui no Instituto, discutimos o sistema de saúde
in the
inglês como
Institute,
dos sistemas
discussed the English
aos quais
health
comparávamos,
system.
né?
Then
Com
we
o sistema
compared
sueco,
this with the
enfim,
Swedish
o italiano, a
system, the
reforma
Italian
sanitária
health
italiana,
system, sanitary Italian reform also.
e é sempre
And
importante,
it's always
né,
very
a
important
gente compreender os
to
movimentos
understand the movements
desses sistemas.
of the
Não só
system. Not
para,
only
diz aquela história, né, que
to
as pessoas às vezes ficam um pouco bravas
many times
com
people
comparações.
don't
A
like
gente, quando olha para a
comparisons, but
grama
when
do
we
vizinho,
look
vê
at
que ela é mais
the
verde que a
grass
nossa,
of our
a gente
neighbor,
quer
we
saber
see
por
that
quê,
it's greener
né?
than
Ou
ours. We
por que
want to know the
funciona, o que
reason.
não funciona,
What works,
quais
what
são
doesn't work, why
as
is the grass
experiências lá que a
greener
gente
in our
pode eventualmente
neighbor's
aproveitar aqui,
garden
especialmente no campo
better
da
than ours?
pesquisa. A
What
gente
can we
produz
take advantage in
evidência, produz
research?
pesquisa,
We
então
produce
esse é o nosso
research and evidence. So
campo,
this is
né?
our grass,
Onde a
our
gente precisa fazer
garden,
perguntas.
where we
Então, a
have
gente
to ask
convidou
our questions. So we
a Adriana,
invited
que eu agradeço desde
Adriana
já,
Castelli, to whom I already show my
a
acknowledgement and
vinda,
appreciation to being here,
a gentileza de estar
and
conosco, né? Nessa
also
semana e
to
pouquinho.
participate in this week.
Então ela vai apresentar
And she will
pouco,
show us a
vai
little
apresentar
bit
o seu tipo de pesquisa que ela
her
desenvolve,
research,
metodologicamente, quer dizer,
methodology and
as
her
alternativas
research, the
metodológicas, os
methodological
resultados da pesquisa, e
alternative
pensar algumas
results of the
coisas que
research,
podem,
and think
ou
about
trazer
some
algumas
things that
coisas que
can
podem
bring
nos
some
ajudar
things to
a
help us
elaborar um
to
projeto de pesquisa.
have a
Então,
research
eu vou
project.
passar
So
para
I will
ela
pass the floor to
e, enfim,
Adriana
após a
Castelli,
apresentação
and
dela,
after her presentation,
bom, a ideia é que a
the
gente tem
idea is
período
for
de
us
debate
to
aqui,
open
né?
the floor for
Perguntas,
Q&As,
considerações.
comments, doubts,
Quem
questions.
quiser falar inglês,
Whoever wants
obviamente,
to ask in
super
English,
bem-vindo. Quem quiser
welcome. And if you want to
falar em
ask in
português
Portuguese
também,
also,
como eu disse, tem
so
tradução
as
simultânea,
I
a gente
said, we
vai
have
fazer o
simultaneous
melhor
translation.
que a
We will
gente
do
pode
our
fazer, tá
best
bom?
that we can.
Adriana, muito
Okay?
obrigado.
Thank you very much,
Bem-vinda.
Adriana.
Welcome.
Welcome.
Okay. Now, I don't like
Bom,
talking
eu
with
gosto de falar
microphones,
com
so I will
microfone.
fight with
Eu
it.
vou
But I
lutar com
will
esse
try to be
microfone, mas eu
good
vou
as
tentar
well.
fazê-lo
So thank you
corretamente.
very much,
Muito
Mario,
obrigado,
for
Mário,
inviting me,
por me
also to
convidar
Dercio,
também, a Décio,
colleague who has made this
colega
happen. It is an honor for
é
me
uma
to be
honra para
here
mim
at
estar
the
aqui
University of the
na
State of Rio de
Universidade
Janeiro,
do
at the
Estado do Rio
Institute
de
of
Janeiro,
Social
Instituto de
Medicine.
Medicina Social.
As a
E
foreigner myself
como
in
estrangeira,
England, I
eu na
really
Inglaterra,
much welcome
eu
this,
também
exchanges
dou
of
muita
knowledge
importância
across
em
different
intercâmbio de
countries,
conhecimento
because
entre os
we can
países,
always
porque
learn
nós sempre aprendemos
from each other
uns com os
what
outros,
works, what
o
doesn't
que
work,
funciona, o que não
and
funciona,
how we can
e
move
como
forward and improve
podemos
our
seguir
own
adiante
healthcare
e
system.
melhorar o nosso
So when
próprio
Mario just
sistema
said
de
that
saúde.
the
Quando o Mário
NHS, the
falou
English
que
NHS, was an
o
inspiration
NHS foi uma
SUS,
inspiração para o
Sistema de
SUS,
Saúde,
o Sistema
não, Sistema
Único,
Universal de Saúde,
Sistema Único de
I was
Saúde,
surprised,
eu
but only a
estava
little bit. And only a
surpresa,
little
mas
bit
só
because
pouquinho.
the English
pouquinho.
NHS is an
Porque o
inspiration
NHS
for many other
inglês é uma
countries.
inspiração
But often
de
what
muitos outros
happens
países.
is
O que
that
acontece
what
muitas
is
vezes é
taken
que
from
o
the
que
English
é
NHS is one way
considerado
of
no
organizing
NHS
healthcare
inglês
that the
é uma
NHS
maneira de
itself has
organizar
moved on
esse
from.
movimento que o
That it might
NHS
not
já
work.
se
So it happened
afastou
also
de
with
muitas
Italy.
coisas que não
Italy is another
funcionou.
country.
É
And
outro
I think
país.
when I will tell you a bit
acho
more
que quando eu
about
falar
the
pouquinho
English
mais sobre
healthcare system,
o
it will
sistema
become
de
clearer
saúde
why we
inglês,
are
vai
so
ficar muito
similar.
claro porque somos
Italy is
tão
another
similares.
country that takes
Itália é
inspiration a
outro
lot
país que se
from
inspira
the
muito
NHS, but it's
no
very important
NHS,
in
mas é muito
any
importante
work that is
em qualquer
done
trabalho que seja
to not
feito,
ever take lose
nunca
sight of the fact that
ficar de lado ou
cultures,
de outro,
people,
porque as
contexts are
culturas,
different.
pessoas,
What
os
works in
contextos
one
são
country,
diferentes. O que
even if it's
funciona no país,
perfect, may
mesmo
not
que
work
seja
in another
perfeito,
country.
talvez não
So
funcione
we need
também em
to
outro país.
translate
Precisamos
always
traduzir sempre
approaches to
as
providing
abordagens
healthcare
para
to meet with the
proporcionar
expectations of
saúde
local
para
population. So
estar de
it's always
acordo
good
com
to
a
have an
expectativa da
example.
população
But
local.
people are
Sempre é bom
different,
dar
countries are
exemplos
different,
que os países
economies
são
are
diferentes,
different,
economias são
so we need
diferentes,
to
pessoas são
be
diferentes,
prepared to
e temos
adapt
que estar
and take
preparados
only
a
what works for
adaptar
us,
e
not
aproveitar o
everything,
que
just because
funciona,
it's
não
the English
tudo,
NHS.
não porque é
So now I will
NHS
start
inglês.
my
Agora eu vou
presentation. This was
começar com a minha
just on
apresentação.
the back of
Isso
what
foi apenas
Mario just
uma
said.
introdução ao que o Mário
So
acabou de falar.
the title of the
Bom, o
presentation
título da
is Measuring
apresentação
Healthcare
é
Productivity During a
Medindo a
Health Crisis.
Produtividade durante uma
Challenges
crise da
past and
saúde,
present.
desafios
The
passados
reason
e
I
futuros.
chose this
O
title
motivo
is
pelo qual eu
because
escolhi esse
although the
título é
methods
porque,
have
apesar
not
dos
changed,
métodos não
what the
mudaram,
methods were not
que
able
o
to do
método não
during the
conseguiu
pandemic is
alcançar
to
durante a pandemia
capture
foi
the health
capturar
produced
a
correctly.
saúde produzida
So I will
corretamente.
give you a
Eu
spoiler
vou dar
alert.
agora um
During the
spoiler agora.
COVID-19
Durante
pandemic,
a pandemia
productivity
de
decreased
Covid, a
by minus
produtividade
24%,
decresceu
coming
em
from
menos 24%,
not a
vindo
healthy,
de
but it
não
was around
de
0% and having had many
30%
years of
e
positive
muitos
productivity
anos
growth.
de
But what it
crescimento
did
de
not
produtividade.
capture
Mas
in
o
that
que não
particular
foi
year is
capturado naquela
by
época foi
introducing
a
lockdown measures,
apresentação
keeping
de
people at
medidas de
home so
lockdown,
that they would
mantendo as
not get
pessoas em casa para
infected
que não
by
se
the
ficassem infectadas
disease.
pelo
The
vírus.
country and the NHS
País e o
focused
NHS
only on
que
patients that
tem foco
really
em
needed
pacientes que
treatment,
apenas
urgent treatment,
precisavam do
emergency treatment, and had
tratamento de emergência e
COVID-19.
tinham
They
a
improved the
Covid-19,
overall health of the
melhoraram toda
population,
a saúde
but
da
we are not
população,
calculating
mas
this.
nós não estamos
So this is a
calculando
big
isso.
criticism
Então,
of
isso é
my
uma grande
own
crítica
work
do meu próprio
that I will tell
trabalho
you.
que eu vou seguir falando. O que eu tenho que ver é que não está funcionando a tela, né? Os mensagens não estão passando. Tudo bem?
Não, estou só aumentando para fora mais um pouco.
Não.
O volume da senhora agora.
I can go. No,
Estou falando alto?
Não, está perfeito.
it's not that one.
Eu não
No,
estou
that's
conseguindo
mine.
passar o slide.
I'm not connected with
Não
mine.
estou conectado, parece, né?
Anyway, I can do it like this.
Bom, eu posso fazer assim, vamos ver.
Yeah, I did it,
Eu
but I need
consegui,
to
eu
go on the...
consegui.
Okay, this is the
Bom,
overview of
Esse aqui é a
of
visão
the session.
geral dessa sessão.
I first introduced
Primeiro
the
eu vou
English
falar
healthcare
sobre
system,
o
which is
serviço
also
de
known
saúde
as the
inglês,
English
que
National
é
Health Service
conhecido
or
como
NHS. So
o
often I will
Serviço
talk
Nacional
about
de Saúde.
NHS,
Vou
an
falar
acronym,
muito de
and it's world
NHS, um
famous.
acrônimo,
Everybody in
que
the
é conhecido no
world
mundo
knows
inteiro, todos
that
conhecem
this is the way
que
we define
NHS é a maneira que a
our
gente
system.
define o nosso
I then
sistema
will
de
give you a
saúde.
background to
Depois
my
eu vou dar
own
um histórico da minha
very
própria
brief, just to
pesquisa,
explain why
rapidamente,
we're
para
doing what we're
explicar
doing,
por que
why this is
estamos fazendo o que
important.
estamos fazendo,
I
por
will
que isso é
talk
importante.
through the
Vou
methods
falar falar sobre os
but the methods
métodos.
are just
Os
for
métodos são
background.
apenas
It's
para
not what
um
it's the
background.
messages that we get from them, how,
São as
what type of
mensagens
results we get.
obtidas, os resultados
And then current
alcançados.
challenges
E
and
depois os
potential
desafios
recovery routes.
e
And I have to say
rotas
that a lot of the
potenciais de
challenges that we
recuperação e
face
muitos
are
dos
the
desafios
challenges
que nós
that the
estamos
Brazilian
enfrentando
healthcare
são
system faces.
os
So they are
mesmos
common
que o
across
SUS enfrenta e são
systems and
comuns
across
entre
continents.
sistemas e
I
continentes.
wanted to spend a
Eu
little bit
queria
of
passar
time on data
tempinho também
sources
sobre
because
fontes de
I know
dados,
that
porque
a
eu
lot
sei que
still needs to be
muito
done
tem
in
que ser
Brazil
feito no
to
Brasil
collect
ainda para
health
coletar
data
os
and to
dados em
share it
relação à
with
saúde e
providers
compartilhá-los com
across
os
providers, across
provedores,
researchers,
com
and
pesquisadores.
yeah, a little bit of pride, although I'm not English, to show you what we have in England,
Embora
and
não
that
seja
might be a
inglesa,
good example to
para
try
mostrar a
to
vocês o que nós
copy
temos
from
na
the English
Inglaterra.
system.
E isso
So let's have a look
pode
again.
ser
So this
ótimo
it works.
exemplo para
So the English NHS was introduced in England
copiar
after the
em
Second
relação ao
World
sistema
War
Inglaterra
in
depois da Segunda Guerra Mundial, em 1948,
and it's known as the
e é
Beveridge
conhecido
model,
como modelo
just like the German is
Beveridge,
the
como os
Bismarck
alemães
model.
têm essa
It was
marca
named after the man, the
chamada
minister who believed
no nome do
in
ministro que
social
acreditava
solidarity,
na
in the social
solidariedade
contract,
social, no
and in
contrato
particular,
social,
the importance
e a
that health
importância
should be
que a
available
saúde
to all,
tem para
not based on
todos,
the
não
clinical needs of
baseado
the
na
patient,
necessidade clínica do
nor the
paciente,
ability to
nem a
pay.
habilidade de pagar também.
More recently, in
Recentemente, em
1989, the
1989,
UK
o
passed
Reino
a law
Unido
to
aprovou uma lei
for the
para
devolution
a
of some of the
evolução
legislative
de
and
alguma
executive powers
dos poderes
within its
legislativos e
countries. The
executivos
UK
do seu
has
país. O
4
Reino Unido
countries,
tem 4
England,
países,
Wales,
Inglaterra,
Northern
País
Ireland
de
and
Gales,
Scotland,
Irlanda do Norte, Escócia.
and health was
A
part of
saúde era
that
parte
decentralization.
dessa
Sorry, it's
centralização.
one of the elements
Era
that
dos
was
elementos que
decentralized.
foi
But
descentralizado.
every
Mas
country,
todos os
constituent country of the
países,
UK, was already
país
organized in the
pertencente ao
healthcare
Reino Unido,
system
já
slightly
estava
different than
organizado
the
de maneira
others.
diferente um do
If
outro
an
no
example
sistema
is
de saúde.
Scotland is a
exemplo
big
é a Escócia.
country,
Escócia é um país
compared to
grande
Brazil, it's a
comparado com o
province,
Brasil, é uma
but it's a
província,
big country,
mas é um
but
país
it has a
grande.
lot of
Tem
remote and
muitos
rural areas. So the
lugares
way they
remotos e
deliver
rurais.
care is
Então, a
very
maneira que
different
eles
to the way
entregam
they deliver
cuidado é
care
diferente
in
como eles
England, which
entregam
is
na
more
Inglaterra,
has
que
bigger, larger cities, a lot of,
tem
a bigger
saídas
network.
grandes.
So
É mais
and
urbano, né?
potentially also
E
the infrastructure is
potencialmente a
better to go to
infraestrutura
the
é melhor
hospital
para
rather
os
than if you live
hospitais,
in the
se
highlands
você mora
and you have only
nas
one road and
montanhas, se
it's
você tem apenas uma
snowing and
estrada, está nevando e
you
uma série
cannot
de coisas.
basically go.
Você basicamente
What I
não pode se
wanted to
movimentar.
put in
O que
here,
eu queria
because it's
incluir aqui,
different
porque é
from the
diferente
devolution
da
in the UK,
evolução
it's
no
different
Reino
from the
Unido,
Brazilian one, is
diferente
that
do Brasil,
it is asymmetric, and it
que é
means that
assimétrico,
Wales,
que significa
Scotland,
que
and Northern
o País de
Ireland have
Gales,
their own
Escócia
parliament,
e
and
o
the
norte da
members
Irlanda
of
tem seu
parliament
próprio
vote
parlamento, e os
for
membros
their
do
own
parlamento
matters, for
votam para
their
os seus
own
próprios
people,
assuntos, seu
and
povo,
England
e a
doesn't.
Inglaterra
So
não.
Scottish people,
Então,
Northern
os
Irish people, and
escoceses, os
Welsh
irlandeses
can
do
vote
norte
on
e os
English matters.
gauleses podem
So it's a
votar
big
nos assuntos
contentious
ingleses.
element.
Então, é um contencioso muito grande, né?
But my focus
Mas
of
o
my
meu
the focus of
enfoque,
my
o
talk
enfoque da
is
minha
about
fala
the
é
English
sobre
NHS.
o
And that was a little
NHS
bit difficult when I was trying
inglês.
to
Foi
find some
difícil quando eu
figures,
estava
because
aqui
some
encontrar alguns
figures,
números,
to
porque
give you
alguns números para
context,
dar
only
contexto
exist for the
só
UK,
existe para o
but
Reino
not for
Unido,
England.
mas não para a Inglaterra.
So what do I need to tell you here?
Então, o que eu quero falar para vocês
Like
aqui,
the Brazilian system,
como o
England is a
sistema
general,
brasileiro,
a tax-funded system based on
o
general
sistema
taxation,
inglês
with a
é
little
financiado
contribution through
com
national
uma contribuição
insurance
dos
contribution,
impostos,
which
temos
is paid
uma
both by the
contribuição com
employer and the
Seguridade Social
employee
também,
before
e isso é
you know,
contribuído
you get
parte
your
pelos
salary
empregadores e
every
parte
single month.
pelos
That's about
empregados,
20%.
que um
And there
percentual,
are
mais ou menos
some
de 20% é
co-payments.
recolhido,
Co-payments
e
or
também tem
out-of-pocket
alguns
payments that are paid
pagamentos
directly out of
eco,
pocket. There's,
que
as you will
são
see, there's very little private medical
desembolsados
insurance,
por
and these
alguns
are
seguros
for
de saúde
dentistry,
médico,
ophthalmology, and
dentistas,
for prescription, community
oftalmologistas,
prescription
ou uma
only. By community
prescrição
prescription, I
comunitária.
mean
E com isso eu quero
prescription
dizer que é uma
that primary care
prescrição
doctor
que
prescribes to
o
you.
médico da atenção primária
Because
vai
if you're admitted in
prescrever,
hospital
porque se
and then
você
get
for
discharged from
hospitalizado
hospital
e
with
receber a
a
alta
course of treatment, that medication
durante
is
o
provided
tratamento,
free
a medicação é
before you leave
fornecida
the hospital.
gratuitamente antes que você
But
deste
there are lots of
hospital. Mas tem
exceptions.
muitas
There's a safety net
exceções.
around
Tem
community
muita
prescribing,
questão de
dentistry, and
segurança nessa
ophthalmology, as I
prescrição dos
listed here,
dentistas,
that actually
oftalmologistas,
89%
que
of
mais ou menos
prescriptions are
89% das
actually prescribed free of
prescrições
charge.
são
How much is that
descritas como
prescription?
livre de
£9.65
cobrança.
per item listed in every
9,51, por
prescription.
exemplo, por
The children,
item
young people,
descrito. Então,
young children and young people that are
os
also
jovens
continuing with
e
education,
crianças,
the elderly,
os
those that are
idosos,
on benefits,
que
either
são
because they're
os
employed
maiores
or because they have a
beneficiários,
disability, do
ou
not
aqueles que
pay
também
for any
estão
prescription, they
desempregados
don't
ou
pay
têm
for dental
alguma
care, they don't pay for
limitação,
anything.
eles também não
And
pagam por
even
isso.
pregnant
E
women
mesmo
don't pay
as
once they're
grávidas
pregnant and for 12
também não
months
pagam
after.
também
Fun fact,
12
when
meses depois
the
do
12 months
nascimento.
after I had my first
12
child,
meses
the
depois de eu
dentist
ter
said,
tido meu
"Let's do a
primeiro
lot of
filho,
treatments." So
o dentista falou, vamos fazer muitos
most of the
tratamentos,
dentistry
e
in England,
muitos dos
unfortunately, is
dentistas
private.
na Inglaterra
And not
são
only it's private, it's
privados.
very difficult to
E
find
é muito difícil encontrar também um dentista
it is
privado.
one of the big
Então,
contentious
é
problems
um
right
dos
now
maiores
in the
problemas
NHS and
de
whether
contingência que
there will
temos agora
ever
no
be a
NHS,
free
independentemente de ser
they don't like
gratuito ou
to
não.
treat
Mas eles não gostam
patients
de
on the
tratar
NHS, the dentists.
pacientes
So,
no
public
NHS.
health
Então,
spending in
a-
2020 to
o
23
gasto
was
com saúde pública
189 billion,
foi
82 billion
82 bilhões de
which was
libras,
an increase of
que foi um
5.6
aumento de
in real terms from
5,6 em termos reais
1920. So
desde
it's
2019
not
a
unfortunately in
2020.
line with
Então,
inflation.
não está alinhado
So
com a
they're
inflação,
still losing
infelizmente.
out.
Então,
They're
ainda
not
estamos
getting
perdendo.
enough money
Então,
to
não
run
estamos
the
tendo
NHS.
dinheiro suficiente
And
para
even the
poder
higher
gerir o
increase that
NHS.
is,
Mas mesmo com
has been
esse alto
determined
crescimento
set
que foi
last year for this
determinado no ano
year.
passado
Quick
para esse ano,
explanation. The
tem
reason
uma
you look
explicação
at
rápida. A
2
razão pela
years,
qual
so
vocês olham para
22,
2
23,
anos,
is
22 e
because everything
23,
in
é porque
England
tudo
goes
na
by
Inglaterra
financial years,
passa
not
por
by
uso
calendar years, the financing
usamos o calendário
and everything
financeiro
else.
e não
And
fiscal e
financial
não
year
calendário
starts
normal.
in
Então, o
April, the
nosso
1st
ano
of April,
fiscal
and ends
começa
the
em 1º de
31st of
abril
March.
e termina em
So
31
just to
de
give you an
março.
idea
Então,
why
só
you
para
would
dar uma
always
ideia
see
para
2
vocês, então
years
vocês sempre vão
numbers.
ver
There is
dois
also
anos
voluntary
combinados.
private health
Então,
insurance with a
temos
duplicative
aqui
role only. And the
um
reason
seguro
why
duplicado de
sign
saúde
up to
privada
this is
voluntário. As pessoas
to have more rapid access
elas podem então
to
ter um acesso mais
elective care
rápido
and for
para
other services, so to cover
cuidado
dentistry
eletivo
or
e serviços como
or other
dentista,
services that
oftalmologista,
are
que
not covered or not covered
são,
completely
que
by
não
the
são
NHS.
completamente cobertos por esses seguros.
This is the track
Bom,
structure of the
aqui
NHS.
é
So I
nosso
have difficulty
organograma.
looking
Eu
at it
tenho
there,
dificuldade de olhar
everywhere,
ali, de olhar
my
para cá
eyes,
para baixo,
but
meu
it tells
olho.
you that we
Mas
have
isso
different
mostra que
layers,
nós
different
temos diferentes
organizations. We
camadas
start
e
with the
organizações.
Department of
Começamos com o departamento
Health and Social Care.
de
So it's not just
saúde
health, Ministry of Health, we
e
also
também
now it's
social,
called social care.
que chamamos
Because as
de
in Brazil
social
and
care,
many
porque,
other
assim como no
countries
Brasil
in
e
the
em muitos
world,
outros países no
we are
mundo,
aging
nós
as a population,
estamos envelhecendo como uma população.
when you age, you
quando
have
você
also a rise in
envelhece,
chronic conditions,
você também
comorbidities, and
precisa
you not
entender
only
as
need the social care
comorbidades,
element,
você não
but,
precisa só
but also the health.
da parte do componente social, você precisa também do de saúde. Então, eles definem as políticas
for England,
para a
NHS
Inglaterra
implements
e
them on the
NHS.
ground,
E aí, então, isso é
but
implementado
also
no
commission
campo. E
services
também
from
temos os
providers.
serviços de
Either
comissão dos
directly, if
provedores,
they are
que pode ser
specialized care,
indiretamente,
say
se for
kidney transplant
cuidado
as an example, because
especializado,
there's so few of them,
porque
they're commissioned directly by
isso
NHS England,
então gerido
or,
diretamente pelo
they,
sistema NHS do
provide
Inglaterra,
other,
que
other
também
support
prover
to
outro
monitor the
suporte para
performance of
monitorar o
hospitals
desempenho
and
dos hospitais
to help them
e
recover if they have
ajudá-los
some
a
problems.
se recuperar se tiverem
But the
algum
majority,
problema,
as you
mas
will
a
see also from the
maioria,
next slide,
como vocês podem ver no próximo
is the
slide,
actual work
é
is
o
done by these
trabalho
42
que é feito por
integrated care
esses
boards,
42
care
integrantes
systems, sorry.
que trabalham nesse sistema
They
de
were
atendimento
introduced
primário,
only in
que
July
foram, então,
2022.
iniciaram
And again,
em
for the reason I said
2022
before,
e, de novo, como eu
because a
falei
lot of the
antes,
problems
porque
that the
muitos dos
NHS
problemas que
faces,
temos na NHS,
especially when needing to
especialmente
discharge
quando
patients
tem a ver
back to the community,
com a alta
and
do
they cannot
paciente
do
de
it,
volta
is
para a
because there are
comunidade,
not
muitas vezes
enough
isso não acontece porque não
rehabilitation homes,
temos
nursing homes that can take the patients to make them recover because before they can go back to the work. So they introduce this system. It's about integrating health and social care. This integrated care systems, they are local hospitals, including local authorities, local governments, social care providers who are mainly private. They are primary care providers, and they will be allocated a budget, and they need to decide together what the needs are of the local population to improve them. So this is more or less, in this slide you see how the funding trickles down from the department to NHS England and then to integrated care.
Para esse quadro de cuidado integrado, que é responsável pelo orçamento, e vocês devem saber que essa instituição é onde o NHS trabalha também. Estamos olhando para isso como uma ferramenta também para os Estados Unidos. Então, eles dão uma parte do financiamento e eles usam isso para comissionar esse serviço de atendimento primário e também de serviço social, serviço comunitário, que é feito, então, de baixo para cima, para atender as necessidades da população. Esse cuidado primário é um outro elemento contencioso, porque esses serviços e os provedores são completamente privados na Inglaterra, mas eles dão serviço público com dinheiro público, então eles têm um sistema de capitalização que leva em consideração a idade, as necessidades, o sexo da população, o gênero, para então para que possam ser adequadamente enviados para esse centro de atendimento primário, mesmo para aqueles que não tenham tanto dinheiro. Também tem cuidadores. Então, se você precisar de uma visita de um especialista, você precisa ir para o seu médico de cuidado primário. Você tem a rota desse serviço de emergência, mas como você vai ver no próximo slide, com os desempenhos, aqui o primeiro, na sua esquerda, mostra o que os pacientes esperam. Bom, isso mostra o percentual de pacientes esperando mais de 4 horas na parte de emergência. Isso tem crescido com o tempo. O alvo é 4 horas, mas se isso não for atendido, os hospitais vão receber uma multa. Então, aqueles que não alcançam esse desempenho vão receber uma multa. Então, isso é uma das grandes questões na questão NHS inglês em relação a essa meta. E também porque tem alguns leitos não conhecidos para receber pacientes que chegam para os hospitais. Muitas vezes eles não têm os leitos para acomodá-los. E eles falam, você não tem os leitos porque você não tem os pacientes, você precisa voltar na comunidade ou as pessoas não podem ter alta. Essa é uma questão no nosso sistema. Agora, por exemplo, aqui na direita, aqui o tempo de espera para ter um tratamento de câncer. Então, isso aqui foi um problema também durante a pandemia. Tinha muitos casos não diagnosticados de câncer, tinha um debate público sobre isso. E agora o NHS está tentando recuperar isso e tratar os pacientes o mais rápido possível para que eles possam ser diagnosticados precocemente e também tratados precocemente.
Of that treatment.
Que tenhamos sucesso no nosso tratamento. Também, se vocês...
It will cost more to get a patient further down the line than to treat them early. So that is 62 days to treat. Patients who have a suspected cancer diagnosis need to be seen for within 62 days from referral from the primary care doctors. Again, as you see across the line there, it was pretty much met. So that the target is 85% of patients with cancer diagnosis need to be seen, but it has been declining dramatically in the last few years. We are now implementing new technology to diagnose quicker patients, like AI, artificial intelligence, machine learning. I have another example from a personal, not personal, from a friend. In England, once you hit 50 years of age for a woman, you are automatically referred to have a cancer screen, breast cancer screening. A friend of mine went, had the breast cancer screening, and was sent back home. Everything was fine. A couple of months later, she receives a letter saying, we have used your scans with this artificial intelligence, and we think you may have a very microscopic cell that is cancer. She was treated within a couple of days, and it was cancer, and she was giving radiotherapy after, and she's fine. So it's very, very early diagnosis. And I think one of the ways that we can improve the way we deliver care to get better health outcomes, because our aim of any health system is not to deliver care, is to improve people's health, is to make use of this new technology that exists nowadays to pilot them, adopt them, and see whether they can improve the way we deliver, whether we can produce better outcomes for our patients. But that needs data. And that needs the collection of data on a systematic way, on a comparable way across the whole system. It needs money as well. Yeah, it needs money. I will not dwell too much on this further, but if you're interested, I can send you the report where this graph is taken from. It's not my work. I use the NHS for that. So now I talk a little bit about the recovery plan that has been put in place after the pandemic and through which ways it needs to be channeled. So first, the focus is on patient and then improving patient outcomes, but also their experience of care within the NHS. In England, there is a family and friends test that people are invited to complete either after they visit the primary care doctor, or after they have surgery, after they go to an A department, and then they do it on a yearly basis, and then they publish the information to check whether patients are happy with the services they receive, what can go better. So patient experience is very important to the patients, but also to the stakeholders in England. The most important one is to improve the long waits. So when a service, just like the NHS, just like SUSI in Brazil, is offered free to patients, there's only one way you need to select who is gonna be treated first. And that is by making them wait in a queue. That is the price people pay before receiving treatment. And there's a huge literature about using waiting times as the implicit cost for waiting in public in systems where access is free. So the problem is that now in England, I've not put it here, there are 8 million people waiting to receive surgery. 8 million. That's like the whole of London. That is a big, big number. That's the first one. This other one is to improve diagnostics waiting time. So to get patients seen by specialists, have an MRI scan, whatever they need, and to reach this, to reduce the waiting for at least 95% of patients. You know, they're not saying you have to be perfect, but this needs to be within 6 weeks by next March, next year. Again, cancer, big, important plan for the part of the recovery plan element to have faster cancer diagnosis. So at least 75% of urgent cancer referrals to receive a diagnosis within 28 days by March 2024. That's now. We'll see whether they do it. The nice thing is that data will be published. After the deadline, we will know whether the targets have been met or not, and return to the 60-day backlog for the pre-pandemic levels. But there's more. In order to to treat more patients and reduce the waiting time, we need to increase the capacity of the system. You need to build new theaters, perhaps, hire more people. Well, what the NHS is trying to do is to do a little bit of that, but also to change the way they deliver care to certain type of patients that require a planned hospital admission, a planned surgery. I'm working on a project to evaluate this new policy. They're creating what they're called surgical care hubs for patients that have low complexity of needs, but for which there are a lot of patients of this type waiting in the queue at the moment. This is for 7 specialties. I don't remember them all. I'll try to remember. One is hip and knee replacement, cataract surgery, urology, general surgery, and something else. So we are working both with medical doctors on this project and with economists like myself to evaluate whether this new way of delivering care, patients will be seen, all of the pre-surgery preparation will be done as an outpatient before you go to this center. You get your hip replacement, and after 2 hours, you're going back home. It's like a factory. And it is. Fun fact again, these are public centers. Most of cataract surgeries, though, in England are performed by the private sector, though, because there is a private sector in England as well, but they're paid for with public money because the private sector is specialized now in the provision of cataract surgery, and you literally go in 1 hour and you're out. So it is really like a fast food of healthcare delivery. So that is one way. That they introduce, as you always, they introduce different forms of hubs, of surgical hubs. One is standalone, so outside of hospital, in a different city, perhaps close to a city. Not in London, they're all in London though. Okay, so in London you have loads of them. Then you have another model which is integrated within the hospital, but they have staff and theaters just for that particular hub. So they have a different door to the main hospital. And in others, they are ring fenced. So staff, the manager of the hospital decides that 20% of full-time equivalent staff needs to be dedicated every day to this. We need to understand which of this model works best in terms of productivity and efficiency, in terms of health outcomes, in terms of equality as well, because they want to know who is accessing those hubs. Are we reaching out to people on lower socioeconomic groups, or is it just the better off that always use them, as is the case often? I can tell you from another research from colleagues of mine that the people that wait longer are people on lower socioeconomic groups than others. Then prioritize diagnosis and treatment with the introduction of, this is for cancer, but also for other diagnoses, not only cancer related. Again, they're taking the diagnostics test outside of hospitals, either by contracting with the private sector or with other public sector, so that patients that need a diagnosis fast are not competing with patients within the hospital. So you free capacity. So you try basically to increase the pie, your cake, without doing anything really about the cake. It's about slicing it up in a slightly different way. The third point there is to transform the way elective care is provided. This is the surgical hubs, but also bringing discharging patients earlier home to what is called a virtual ward. So they are monitored remotely, so they can free up beds in the NHS. I think the NHS has the lowest number of beds per 100,000 population of all Europe, because there was the idea that in order to be more efficient in the NHS, you should reduce the number of beds and use them more intensively. It hasn't worked, unfortunately. And I would stop here. And the important improving through efficiency change. And this the plan includes all of the target is 2.2 efficiency savings, 2.2% of efficiency savings, which if you have we don't know yet how we're gonna achieve that that target, whether it's achievable and whether it and through which means. NHS England has said that the plan should include actions on those elements. The first one I need to explain is to reduce agency staff. So in England, the workforce is mainly hired by the hospitals, but if you have a need for an extra nurse, but also a surgeon, you sometimes hire it privately, and this is called agency staff. But agency staff cost per hour at least double the same amount that a nurse that is employed by the NHS cost. Because hospital, and that's the solution to hire through agency staff is always a short-term solution to patch up a short-term need. So hospitals do not try to look to the medium and long term and build the capacity over time to increase their work stuff. They say, oh, I need 10 nurses, I'll pay the private sector, and they can. The Department of Health has imposed a cap on that and said you cannot spend more than this amount. And if we look at the data, which I don't have here, but you can see, so they not only put the cap on agency staff, but they also said, if you want to use extra staff because your needs, you can build a bank of your own staff that say that they are available to work extra shifts. And they have a 0-hour contract, meaning they're not paid anything if they don't work. And if they are called to do the extra shifts, they get the same salary as they would if they were working for the normal shifts. So when we look at the data after the Department of Health introduced the cap, you see agency spend decreasing a lot and the other. So some policies do work, and it's cost efficient because you're using nurses, you're trying to patch up your needs, to respond to your needs, but you're doing it by spending not too much money. The other important thing to remember is a lot of nurses were agency nurses and they were working in the hospital. So they would sometimes go back to work in the same hospitals with a higher salary as agency, but not as employees. So it addresses a lot of issues. Another way, and I think this is also true potentially for Brazil, is to purchase medicine at the most effective price point. A lot of debate has been done in Brazil, I think, about the generics, that you're not using enough, generic brands, that you don't prescribe enough generic brands. So medicine that don't have a brand, so they're generics, but they have the same chemical compositions at the branded. In England, it's pretty much a thing, people do use it a lot, doctors, everybody uses it a lot. But also in England, the way medicine is prescribed, you only ever receive the amount of treatment that you need. So if you need antibiotics, they don't give you the whole package with 24 pills. They give you only 5 if you need to take 5 pills. So every prescription is prepared personally for you. And we wait a lot to receive it as well. But anyway, I'm not putting on everything because I'm conscious of time. It's very interesting to talk and to find points of contact with yours, but we can discuss that also later. So now to my research. So why is it important to do this work? Governments, because the money that goes into NHS is public money, the government as the main stakeholder wants to know how this money has been spent. If we're increasing the resources on inputs, are we producing more outputs? Are we treating more patients? What are the health outcomes of these patients? Are we improving those as well? But the citizens also are very interested in that because it is their money through the taxation that goes and funds the NHS. So in England, there's a big interest from citizen groups in that the money that is spent to NHS is producing what we call value for money. One way of determining whether that is happening is to measure the productivity of the NHS. It's only one way. There are lots of different methods. Our method is embedded in an index number approach. So it's not stochastic analysis, it is calculus. And we follow the system of international and national accounts, which is embedded in the system of national accounts and the European system of accounts. And I believe Brazil has also, as a country, needs to report on health accounts at the national level. So it's very similar. So what is productivity? Productivity can be measured as an absolute measure for, say, 1 year, one hospital, whatever. And it's the ratio of outputs over inputs. So how many inputs have I used? How much output is produced? If that ratio is greater than 1, you have a positive productivity. You're doing well because you're getting more out than you put in. If it's below 1, you're not doing that well. What we are doing is we measure productivity over time. So we're looking at productivity growth. So we're looking at how output has changed between 2 consecutive years and compare it to the input has changed between the same 2 consecutive years. And that's how you can have different ways of looking at it as well. What do we use in terms of outputs? So outputs, we include all healthcare services provided to public patients, only public patients. It also will include patients that are treated in the private sector, but are paid for with public money, okay? And we divide them by these categories that you see here. We have information on hospital inpatient activity, outpatient or specialist visits, primary care, prescribing, community care, A&E, and all the rest. Community mental health is in red. I know that, Rossano, you are a mental health practitioner, is in red because they've changed the way they've collected the data over time, that they're not comparable anymore. But I have another project which I only looked at the productivity of mental health trusts in England. So I've developed now, which is about to be finished, and that's a work where we're just looking at mental health trusts using different type of data. So this output, as you can see, there are lots of different types of output, and they're very different. You know, a hip replacement is not the same as an open heart surgery. And in order to aggregate them in an index of output growth, you need to have a weight. You need to know that cataract surgery is only 1/3 of value of an open heart surgery, of a cancer treatment. And this is what we suggested initially, was to use patients' evaluations of the different healthcare treatment, but or called also value weights. But these are not existent in England, and we are very advanced in data collection for various reasons. They need to be updated every single year, otherwise you will not capture change. And it's for a lot of categories. Just for inpatient, the inpatient activities organized in HRGs, health-related groups, similar to diagnosis-related group, actually. And there are 1,700 of them. So that's just for one sector. So what we do instead, we're using information on costs of production that are publicly available exactly at the level that we need for this, because every hospital and every healthcare public hospital, I should say, and provider needs to report the unit cost for every patient that goes through their system. And these unit costs are collected at the level of the single patient now. So it's patient level cost information. So it's very good data. And this using unit cost of production instead of value weights is also recommended by the system of international accounts, because they realize that this value weights, although they're ideal, are not feasible to collect. But they recommended, and we did, to use quality of care to adjust. So if you think of a market output, a car, cars don't all cost the same, right? And the cars that have better specifications, better quality, cost more. What we're saying here is, by capturing the quality, we're giving it even more weight if there's a positive change in this quality of health in non-market output. So they have different quality characteristics. I will tell you when we look at the indices, I will tell you a little bit more what we do. And they're different because, again, certain sectors, although we're very good in England in collecting data and everything, some sectors are better than others. So we have quality adjustment only for inpatient care, both elective day cases and emergency. For outpatient care, we're using waiting times, and for primary care, that we use waiting times and management of certain groups of patients. So whether they receive a blood test control or not in a given year, because data is not available for everything. So I'm not delving why this formula. You just have to take it that this is what it is. This is our output growth index. So the elements are, the first one is the output. So this would be the output of type J. If it's inpatient activity, it would be the DRG, say the hip replacement of a patient more than 18 years of age with no complexity. So it's very specific. And to that, we assign the cost. And the cost exactly specific to that particular patient. And we do it by assigning the cost of the previous year. So we're using what is called a spare volume index, because we're interested not of the effect of changes in prices or values, but we are interested in capturing volume effects through time. That's one. The delta QJ is the quality adjustment. Sorry. Which is here. So the first element, or the first two, the first is survival rate. So we know from our data whether the patient has died in hospital. We also know if the patient has died 1 day after he was discharged, 2 days, 30 days. We know the date of death. At some point the patient dies, we know that because we link data. We use in-hospital mortality only. The international standard is to use 30 days mortality after discharge. We had a period where the Office for National Statistics that provided that data was not very happy to share the data with us. So we swapped from 30 days to in-hospital, but the correlation between the two is 99.9. So if a patient is dying after treatment, it's more likely to die in hospital than to die at all. So it's very high, the correlation. That's the first element, the A. The K looks at health outcomes. So in the past, it was 4 treatment, vein removal, hip and knee replacement, and cataract. The hospital also collected, if it was an elective or day case or planned admission, planned surgery, collected health data before the treatment and after the treatment. And that's what we're doing. We're adjusting that. And we combine that information with life expectancy. Life expectancy is produced by the Office for National Statistics by gender, by sex, age, by sex and age. And because we know that information from our health data, we're able to link every year their life expectancy remaining. And we're trying to get a measure of quality of life, basically. So if a patient survives treatment with this health outcome and then lives for another 30 years, then the overall quality produced by the hospital is X. And that's what we're trying to get. At the time we developed this measure, which was 20 years ago, waiting times were a big problem. Again, they're a big problem now. So we also correct our measure of output, of the cost-weighted measure of output, by looking at waiting times. So whether between one period and the next, the number of days patients spent waiting has increased or decreased. And the way it's included is that the longer the way you wait, the less value the NHS is producing, because it's a cost, it's a negative cost. And that's it. Okay. The top one is just for outpatient and primary care activity. That's how the adjustment for waiting times looks like. It's a bit different from the other one. The bottom one is the more important one that I wanted to pay your attention to, is that, and this is a new one. So a lot of patients, because of this issue that we should discharge them to use the beds more quicker, they come back. They come back quickly. Emergency readmissions. And a lot of patients that come back quickly. Again, the measure we use is within 30 days from discharge. So if a patient comes back within 30 days of being discharged, that we count that. I will explain you how we count that. But with a colleague of mine, I work on a different project where we actually question whether 30 days is the best time interval, because within 30 days, the patient could have an accident and it's not related to the reason they were in hospital in the first place. So it's a bit complicated. And we also looked at hospital-acquired infections, MRSA and C. diff, not COVID, because there was a lot of cases, but these two. The reason these were picked is because we did a review back in 2016-17 with different stakeholders, Department of Health, ONS, three important think tanks in England, the Health Foundation, the King's Fund, the Nuffield Trust. We developed some criteria to choose between different indicators of quality because they need to be used specifically for a measure of productivity. So one of the criteria is that there's consistency in the way that information is recorded over time. If it's not, you cannot compare. That it's timely, that the data is available for the ONS and for us to produce the statistics. If it's available after 3 years, we cannot do it because we do this work every year. So these met all of our criteria. And what we call them, they are bads. So the one that you found in the upper bar, the X, is a good, it's the output, it's the positive, it's the care you provide. If you come back or if you acquire an infection in hospital because something is not working, we take that value of that output away from you and we call it the dead weight loss. So we were very excited about this. Then we crunched the numbers. They don't make a difference, unfortunately. So in absolute terms, they are big, but the value of that activity is very small to the overall value produced by the NHS, that their effect is on the 3rd decimal point of the output growth measure and 5th or 6th of the productivity measure. So, but we are excited about this improvement of the measure. Maybe it will be important. Input growth. So we looked at the output. For inputs, I told you we're using a volume index because we want to know the change in volumes. I need to repeat this here because for inputs, we look at all the inputs of production. Now it's a very technical term to use input, but we're looking at staff. We're looking at material, intermediate goods and services and capital as well. And we look at these, how these change from one to the next. These factors of production can be calculated either directly, if you have information on their physical units, the number of staff and their earnings, or how much money you spend on how many toilet papers. Or we use an indirect measure by using expenditure. Expenditure is less tricky. It's a bit more tricky. I don't know, there's something missing here. It doesn't matter. It's a bit trickier to do because we have to do a separate thing. Again, data availability in the English NHS tells us that we can only measure changes in volume of full-time equivalent staff directly. So we have the information of how many surgeons there are in the NHS, of which level, and the average earnings, and are able to include them in our measure. For the rest, we use an indirect approach. So we use expenditure, but expenditure data is conflated by inflation, changes in prices. So we use deflator to wash out any effect due to prices and get to a change in real volumes. And those two, the last bit shows you the mathematical equivalence of the two. So they're equivalent as long as your deflator is good to do the job. So now I think we go, that's it. And here, when we then calculate productivity, we calculate two measures, an indirect measure that uses expenditure on staff, intermediates, and capital, and what we call a mixed, where we use the beta measure for the staff as the direct input growth measure for staff and combine it with information on expenditure, using expenditure data for intermediate and capital. So that is our productivity measure, how it looks. So you then take your output growth measure in every 2 financial years, you compare it with the input growth, and finally you know whether the productivity of the NHS has been positive or negative between 2 particular years. This is, okay, here we go. This is our data. So this is all the data, the different data sources that we use for the different types of activity. I divided them between activity information and cost information because sometimes they might be different. And I also listed how they changed over time. We have a lot of data. To access data, we need to go to NHS England. Long application. I'm the lead for applications for data and also the chair of data governance in my department. So I'm very keen that all my colleagues use the data responsibly. It takes a long time. It took us the last time almost 12 months, 11 months to get through all the levels of permissions. But once you do it, you can use the data for all your different projects, with some scrutiny, but you can use them. It is a long, but the idea in England is that we need to share data for research. Because it's only through the sharing of data responsibly, it's all pseudonymized data. We are not able to identify any patient at all. Can we get to the improvements in the way we deliver care? Because people are studying them. So they're very, very keen to do that. You can either get the data right now, send to your department, and we have created what we call a data safe haven. So it's a structure where we access through, I would say, double, triple login, dual, so many dual systems that we have to go to remembering passwords. We need to change our passwords every 90 days for security. They need to be at least 16 digits long. It's a lot, but at least we can use them sensibly. Fun fact again, University of Manchester was hacked recently, and they lost some NHS data. So they are not receiving data anymore. So we need to work very hard to keep the security, the access, because it's so easy. So we have all, for example, managed laptops that we can only access through University of York dual identification. And we need to work in VPN. Everything has to be changed. Every time I log into anything that I need to write my username, the password, click, send me a button on my phone, approve, it's me. And then I can enter. So a lot of scrutiny, but it is good because this is sensitive data. We need to respect patient data.
Muito sensível do paciente. Precisamos respeitar isso.
For inputs, we have very good information on the financial
as entradas
accounts
também. Temos muito boa informação da parte financeira dos hospitais.
Also on electronic staff
e também registros eletrônicos.
We are able to identify 556 different types of hospital staff.
E tantos hospitais.
If you want an idea of how they look like, I can give you a screenshot of the names, not of the data, but at least the names. We can talk about it. So numbers. I on purpose gave you here what the productivity of the NHS looked like in the last 3. It's 4 years, 4 years, but 3 growth rates. To give you an idea of how it has changed over time. So the first one,
de como isso tem mudado com o tempo. Então,
NHS was not impacted still by COVID. So the only months in that year, 1920, is March. But if you were to read my report for that year, because we provided monthly analysis of the data, you see a complete drop of activity in March. So hospitals were asked by the Department of Health and NHS England to stop all elective care and to prepare to receive COVID patients. But from April, but they stopped in February before, and you see it in the data. How
nos preparássemos para receber os pacientes de COVID.
They were only treating emergencies and and COVID patients with and a lot of the staff was redeployed from one ward to treat COVID patients. So that's one. So I believe it's minus, if you look at either measure, it's minus 2%, say minus 2, 11, 14%. Look at the COVID year, which is the middle one, minus 24.02%. As I said at the very beginning, when I said spoiler alert, this is real because following our method, we compare outputs in one year with the other, and there was a complete decline in outputs, but it did not take into account of all the public health measures that were provided to keep people safe at home. We could not measure that. We could not give them a value.
Mas isso não levou em consideração
all the avoided cases of COVID.
Dar valor ou incluí-los. Todos
so if going
os casos.
Forward, when I will show you also the graph, I asked the people that I work with to trend it out because COVID year is not a real, it's an external shock, like the economy. It's not real. And we should not look at that to see, to say the NHS was bad. Because they really saved lives. They were not, they did the best they could in very new circumstances where you had to learn a lot. It's also very negative because the input growth, if you look at the indirect, they grew by 10.49%. The previous year was 2.41. That's 5 times more. So now look at the data between 2020 and 2021, 22. And you think, that's amazing, productivity is back at 15.18%. That's not real. Because if you compare it to pre-pandemic level, you see that the productivity growth is still negative. So we need to ignore that this particular year, because there was recovery. Certain output, certain sectors, I can't remember which one it was, they grew by 100% because they stopped activity during the pandemic, then they started again. And because of these intricacies with the way the measure is constructed, it can sometimes give you the wrong measure. So we need to be careful. So with my team, we decided to report the growth, but also do something else. Say, are we recovering? Is the NHS recovering to pre-pandemic level? Well, it is recovering, but it's not there yet. There's still a productivity gap of minus 13.41 or 12.56%. How can we, so this is how it looks like.
Como que,
então, aqui,
podemos lidar com isso. Aqui é como se parece, a produtividade e o crescimento, essa linha aqui de baixo, a de cima, que está em vermelho, são os crescimentos dos outputs, e a do meio são o crescimento dos inputs.
So we index growth to 2004-05.
Cresceu de 2 para 5.
My measure goes back to 1998, I think. So I have a longer time series, but it's too long.
Tenho aqui uma série de mais tempo.
So as you can see, up until 1920,
como vocês podem ver, até
1920 a bit,
até
19,
20 ou 18, 19, estava crescendo a produtividade. E depois,
introduced with waiting times were already declining, and it was on a decline, but it has been growing. And then you have the break in the pandemic year 2021.
Cresceu. Depois,
massive dip.
2021,
so the dashed line in productivity shows you how it is changing to pre-pandemic level, and this is the real story here. It's not the one in between.
Desde a época pré-pandêmica. E essa história é real.
This is actually, I should have said it before, you're the first one to see this data, so they are still provisional.
Mais relevante. Então,
because the report will come out at the end of
porque o relatório mesmo vai chegar, vai ficar pronto no final desse mês.
This gives you a little bit of an idea for output growth by different settings. I will not dwell on this. I will show you this.
um pouquinho de uma ideia para mostrar qual dessas configurações contribuem mais para a medida de crescimento do output. E o maior contribuidor são
they treat a lot
os
of
pacientes
patients, but the patients that
hospitalizados.
treat
Não é porque tratamos vários pacientes, mas os pacientes que nós tratamos custam mais para o sistema porque usamos um custo unitário para agregá-los, porque tem muito mais pacientes nos ambulatórios, mas o custo é menor em comparação à atividade hospitalar, e mesmo mais pacientes nesse atendimento primário, eu não sei quantos milhões, 800 milhões, mas o valor desse atendimento é menor. E aí você tem essas contribuições de 5, 6%. Então, o primeiro, a coisa interessante aqui, a primeira coluna de azul claro é o compartilhamento do gasto geral, e o segundo é a contribuição para o crescimento. Então, vocês podem ver que entre esses 2 anos, o compartilhamento desse gasto geral para os pacientes hospitalizados foi menor do que a contribuição, foi maior. Se vocês olharem no outro ano, isso foi porque no ano da pandemia, ao invés de ter os hospitais pagos com tarifas ou recebendo
block of payments and they could spend them, and we noted a massive increase in overall expenditure and also in the unit cost of each patient
nesse gasto geral e também no custo unitário de cada paciente.
So this is for input. No, this is the quality adjustment.
Então, isso aqui é para os inputs.
So as I told you, we adjust for
quality. Ajuste de qualidade, como eu falei, nós ajustamos para a qualidade também. E
very small impact.
Impacto muito pequeno.
In our case,
nesse caso aqui abaixo,
what is it called?
Cadê onde é que está?
In the last year, the quality adjustment,
a qualidade do ajuste,
I think it increases the value of the output produced by the NHS for hospital inpatient, but in some years it
mas em
decreases
alguns
the
anos
value
diminuiu o valor.
As well. So the contribution is minimal, but
a contribuição é mínima, mas pelo menos nós a capturamos.
This is the inpatient growth again.
Então é o crescimento das pessoas hospitalizadas por diferentes tipos de
inputs. As you see here,
vocês podem ver
I can differentiate between agency and bank as well. And you
posso ver aqui a diferença da agência do banco.
I don't have the time series here, but it used to be 25%, 6% agency staff. It was really high, but it had the decrease over time. And again, the NHS, I think, and in any health system, NHS is mainly a labor-intensive system.
Principalmente um sistema de trabalho intensivo, e isso contribui muito para o crescimento dos insumos. Então, outro desafio atual para corrigir essa rota é que, no momento, todo mundo está interessado. Como que nós aumentamos a produtividade? Eles usam a produtividade
narrative in the discourse right now,
como discurso.
By the government, by NHS England, by the Treasury, to mean many things. It can just mean increasing turnover, spending less time in theater, but it's all the same. As you saw here, the way I define productivity is one precise measure. But the policymakers may use it in different ways. At the end of January, we hosted 10 senior policy advisors from the Treasury, because they wanted to learn more about how we measure productivity. And one of the comments we received was, now we know, we didn't know that you measured in this way, and it's very useful to know, because our measure is used by the Department of Health,
usada pelo Departamento de Saúde para voltar para o governo e dizer, vejam como nós somos produtivos e nos dê mais dinheiro. Então, eles usam isso para gastar.
My work has been discussed in Parliament, has been discussed in spending reviews to give more money to the NHS, but you need to demonstrate growth.
Para dar mais
so this tells you the roots, the potential roots, which is part of the recovery plan. I've mentioned more of them already at the beginning in January when I was talking about the issues of the health system. I just put some here because I wanted to give you also all the links with something, because I'm happy to share the slides with you, and if you wanted to read more. I just want to draw your attention to the third bullet point. It's just to tell you there is research done in this famous delayed discharge. So people that are ready
uma pesquisa feita
to leave
sobre
the
as altas
hospitals,
hospitalares.
but they need
Então, se as
some
pessoas que
further
estão para sair do
support, they
hospital
cannot go
precisam
back
ainda de
to
um
their
suporte
homes. It is
adicional, elas não podem
especially true
voltar
with
para
older
casa
patients
simplesmente.
that they might need
Então,
to go
isso principalmente
nursing
acontece com
home,
os pacientes
or
mais idosos
maybe
que
the
precisam de
council, the
enfermeiros,
local
ou
government
talvez
needs to install
os
a
consulados,
stair
os
lift.
governos
They need to
locais
assess the house
precisam
to see
ter
whether they can.
lar, algum lugar para receber
One
essas
thing,
pessoas.
most of the houses
E
in
muitas
England are
das
small, they're
casas
not
na
apartments.
Inglaterra
So
são
you have
pequenas,
different
então
levels.
você tem níveis diferentes.
And some of them, the
E
toilet
algumas
might only be on
delas,
the
ou
first
talvez o
floor.
toalete
If
só
an
tenha no
elderly
primeiro
person had a
andar.
hip
E
replacement, they cannot go all the
toda
time
pessoa idosa que às
to the
vezes não
toilet.
consiga
So
ir para, não
the
consegue ir com tanta
council goes
facilidade
to
para
the
o
house,
toalete. Então,
assesses the
eles vão
conditions, and if
para
they
as
need to
casas,
install a
veem as
toilet or a
condições.
lift, they will do that free of charge. But the patient cannot go home, and it will take a long time to wait. There was one patient in Wales, so not in England, that stayed in the hospital for a full year, 365 days. Is still in hospital, actually, last time I checked, because she cannot go home, and there's no place in the social care system where she lives. So it is a big, so the delayed discharge is a big problem. But it's not a problem of the NHS, it's a problem of social care. Another thing that I would like to tell you about social care is NHS is funded through general taxation. Social care is through means testing, it's mainly private. And again, I was talking to my friends Yederso and Erika a couple of days ago. If you need social care, if you need to go to a care home, the government says, that's fine, we can pay for it, but let's see how much money you have first. So they will assess all the assets. They will have to pay with their own money until all of their money goes to zero, and then the state comes in. Some nursing homes cost £3,000 per week. Per week. So it's a lot. So, and I think I finished. Thank you very much.
Okay. Now it's open to questions, comments. I think just to maybe to start, yes, to break the ice. One thing that is to me interesting since the beginning, that she showed one, the complexity of the system. Second, that most of us, or the common sense, that NHS is, many people made the comparison, SUS, NHS, etc. Nothing to do, or a lot to do. Private sector, waiting list, infection, post procedure, post surgery, etc. So I don't know if you remember the list of the waiting list for surgery in the orthopedy, National Institute of Intro. People waiting 5 years, thousands of people. So yes, we're not alone. So open for questions or comments, please. Quem quiser falar, comentários. Maybe there's a need to talk in. Para o benefício da tradução. De quem está nos assistindo no YouTube.
I am also surprised with the similarity between SUS and the NHS. That's a surprise for me because I always think about the NHS as a somehow a paradise system that everything works well, but your problems are very similar to our problems. I have two questions, one more specific about how you calculate the efficiency in these pandemic days. I saw that you explained that you have a different way of calculate between the years 19, 20, and the 2021 and the 21, 22, and another number for the results when you came from the 1920 to 2021, 22. Because the slide before, but no, in the graph. Yes, but my question is that there are some different outputs in this period that are not captured by your method. I thought that your method captured the regular outputs, but in this period we have special outputs, different outputs that your methodology is unable to capture. My question in that way, if there are there are efforts in order to capture these different outputs, because I think that if you can capture these outputs, the productivity remains growing. That's the specific question. Yeah. The another question is about how do you address the problem, if you have, of medical doctors and other specialists in the countryside. Here in Brazil, you have a very big problem with it. You have a special program from federal government that's called Mais Médico, more medical doctors, that has many strategies to send the doctors in the countryside. I'm not sure about the efficiency of it, but they are trying. I would like to know how you address this problem if you have it.
Any other question? Paulo, Eliseu. Paulo, please. So otherwise, nobody will listen to you.
Yes, talking about the similarities and difference between the NHS and the SUS. One aspect that I noticed, which is very different, is the growing of the private sector in England. Healthcare, private healthcare. I noticed a difference, a huge difference from, let's say, 30 years ago when I lived there. And there was very, very few people who used private care. And now I spent the last year there, and I noticed it was, of course, I stayed only for 1 year, so I could not see as well as I saw when I lived there for 10 years. But I would like you to address that. Have you noticed, or is there really an increase in the private system? And if that's the case, do you think that there is a risk of creating a two-tier system in England? Because that's, I think, is a big difference from SUS and NHS, because here in Brazil is clearly still a two-tier system in which the poor use the SUS and the middle class use the private system. I don't see this happen in England yet, but I was a bit worried this last year.
It seems that's coming, no?
Yeah, I think, but
they went private.
yeah, so So just to finish, do you think there is a risk of that happening? And do you think there is a kind of resistance to that you think it will be able to avoid that?
Good question. Very good. Is it working? Yeah. Yes, it's working. Thank you for the very good questions. Thank you for a very good question. So the first question was, how is productivity calculated or growth calculated when the output changes from one year to the next? And I should have said, we have developed a method to account for that. So the Office for National Statistics, which is the official measure of productivity, they use our quality adjustment, by the way. So every year they come to us and then we send it to them. They don't do that perfectly. So the majority of their output is, if you want, equivalent from one year to the next. But because we had that issues, and because we spend a little, being academic, we spend a bit more time perhaps than just statistician, we have addressed it by developing what we call the imputation method. So we try to not lose output if it's coded in a slightly different way. That applies in particular for prescribing, from the move to branded to generic, because you might not have exactly the same. So we actually look at the drug composition rather than at the name of the brands, for example. For other outputs, if we are able to say that the way that inpatient activity is categorized changes from one year to the next, and it did change. It went from 356 DRGs to 1,700. So it wasn't very similar, and that's when we developed this imputation method, because we assume that the patients are still treated. It's just the way they are categorized that is different. So if you remember, if I go. Yes, so the numerator says we use the cost of the output of the base year to determine the value also of the current year, and because we're interested in changes in volumes, okay, not in prices. So if there's a new X, they will not have a cost from the previous year, right? That's one of the issues, but we are including them. So what we do is we deflate the current price through a proper deflator and still are able to include the output. Your question had two components. So we are able to include output that changes in the way it's classified over time. If it's completely new activity, we include it, but we caveat it to say that there's a new activity, especially if the new activity costs a lot. So in 21-22, we noticed that there was a new activity that was costed per unit of activity it was I think a high cost drug. It cost £1 million per drug, and it was to save babies that would not otherwise survive. The National Institute of Care and Clinical and Care Excellence, which decides on which drugs should be prescribed, introduced into the system based on their cost effectiveness, approved that drug for treatment. And there were only 7 babies that needed the drug, because it's a very rare. So we found £7 million, 7 activities. So for the new year, that drug is not included, but we caveat it and we reported to saying we have done this. For the pandemic, the issue was different in the sense that for elective and day case activity, surgeries, planned activity, there was zero. There was nothing. For new activities that were provided, like COVID tests or vaccinations, we tried when the data was available to include them in our measure. So those are included. But we did not have, we only had the total number of vaccinations provided in primary care and primary care networks, but not the vaccinations provided by hospitals. And we did not include the value of the vaccine because it was private, confidential information. So the Department of Health could not share the data with us. Yeah, so again, in our report, it is written. So we are very transparent of what is in or not. But when an output changes slightly, if it addresses the same clinical need issue, we try to include it with this imputation method. So the other question, specialists in remote areas, how are these addressed? This is not, it's tangential to this work. It is an issue in England. It is an issue, especially in primary care. And it is an issue if the remote area is also a poor area, because the primary care doctors don't want to move in a poor area. So it's not only an issue of remoteness, it's also an issue of deprivation. Primary care doctors do not want to work in an area that is deprived or remote and deprived. There are lots of remote places in the English countryside that are idyllic with private schools. They have too many doctors because they want to be there. But those that have a combination with deprivation are understaffed. They lose the understaffed, and there's issues with recruitment and retention of doctors. It applies also to urban areas. Interestingly, near York is a place, I think Scarborough it's called, it's a coastal. They have no primary care doctor, we call them GPs, general practitioners, wants to live there, wants to go there. So what happened during the pandemic, and again, the NHS is trying to learn from the new way of delivering care. A lot of these primary care doctors, they're private, but they are in networks, or they have more than one clinic. And there is one in particular in York, which is one of the better ones, that has also a clinic in another city, Hull. I shouldn't make names here because you will never want to go there, but it's on the coast as well. And the doctors from York delivered care remotely to the patients in Hull. So again, you might need to use for here perhaps telehealth and telemedicine to address the gap of remote areas or deprived areas if you have an issue with deprivation in this country too. Obviously, it's not for everything. If you need a surgery, patients will still have to move to the bigger cities. So that is, I hope that I've answered both of your questions. If not, we can discuss it later. The other, private sector growth. So let's go a little bit back. You're absolutely right. Your observation is correct. It has been increasing. And the NHS, because of the capacity issues that I've explained before, if they need to treat patients and they have long waiting lists and the hospitals are fined for keeping patients waiting too long, they go to the private sector. So the private sector is specialized in usually low complexity procedures, things that are easy. They don't do very remarkable, unless it's a very specialist hospital like the King went in London. They treat easy patients. Most of the difficult, the patients with higher complexity are treated in the public NHS, including private patients. So private patients can be treated in NHS and they pay privately. I had a private woman I gave birth as well. I paid. Anyway, so it has been growing, and it has been growing because when David Cameron David Cameron is Tory, came into place with the changes in politics. He introduced, so before Cameron, I think it was Tony Blair, introduced choice, patient choice. So patients should receive the choice of where to receive care, and the choice was limited to the NHS. So it's if I want to go to London to receive a specialist visit and I have the means, the time, I can go. It's very inequitable because again, it only allows the better informed, the better off to take advantage of this. But David Cameron in 2010 opened this choice to any willing provider, including private sector. So that's why you have seen this increase. The amount of people with private health insurance, or the percent, hasn't changed that much. It's 10%. It was roughly 9%, so it hasn't increased that much, but the offer from private provider has increased. You're absolutely right, yes. They're called independent sector provider or treatment centers. We have some in Europe. During the pandemic, all of the work of the NHS, even blood taking in York of the hospital, was contracted out to the private hospital. Everything. So when I had my blood test done, I went to the public hospital. Said, not here, you have to go across the road. They're very close to the Nuffield Trust and have your blood taken there. So you're absolutely right in your observation. I think it's you said there are increase and the risk of the tier 2 system. It is discussed a lot, but I think it affects a very small part of society still, because you can be treated in the private sector but not pay anything still, right? If you have a cataract surgery, it's more likely that it will be a private provider that give you that surgery than a public provider, just because they don't have the capacity or they don't want to do it anymore. But it's not like here that the rich and wealthy use the private sector because they have private health insurance. This is open to anybody, but it creates a bit of, if the information is not there equally for everybody, for the different strata of society, then there might be a problem in who receives care first. The creator of the NHS, the choices of any different providers was an economist and social scientist. I don't know whether you know him, Julian Legrand from London School of Economics, and he introduced this importance of choice, of patients' choice. But I told them you need to give patients a voice, not a choice, because the poor strata of society, they don't know about this. They don't know about that they can go to any provider. I went to a different neighboring town to receive a specialist visit because I looked at the data. In York, I needed to wait 18 weeks. In Harrogate, it was 2-3 weeks. Where did I go? To Harrogate. But not everybody has that. Not, so you asked, do I think there's a risk of a two-tier system? If you listen to politics now, and I'm not a politician, okay, I'm an economist, so I use science, not words, to recommend policy. There is a movement to privatize the NHS. There is. So there is this tendency, this discourse, this people talking, right-wing people, Tories, saying that we would be better if the NHS would be private. But they don't know that the majority of people, left, right, and center, they actually are very proud of the public system. Very, very proud. If you remember the 2012 Olympic Games, the opening ceremony, there was a big representation of the English NHS because people are proud. Well, no, they can be unhappy with some part of it, but they're proud of their system. They're proud that people can access care based on their needs. Yeah.
Okay. Mais alguma consideração? Obrigado, Paulo. Acho que a questão é importantíssima, né? Interessante, quer dizer, essa distinção que ela faz e que eu acho que importa para a discussão nossa, que é o aumento da oferta, mas um certo manutenção, estabilidade do número de pessoas ou da percentagem da população que está assegurada no setor privado. No Brasil tem alguma coisa semelhante, mas, por exemplo, essa análise pode ser, a gente faz análises comparativas, pode ser interessante. Quer dizer, tem aí 40, 45 milhões de pessoas asseguradas no setor chamado supletivo, né, suplementar, mas isso é mais ou menos 20% da população brasileira, isso tem se mantido, né, aparentemente, com diferentes formas. A gente tem um formato aqui que não tem lá fora, que é plano de saúde, que é uma expectativa de ser atendido, diferente do seguro, né? Então, enfim, mas, de qualquer maneira, a ideia de que o setor privado, por outro lado, a oferta tem aumentado muito, particularmente nas áreas urbanas capitais aqui no Brasil, que é um pouco o que acontece lá com o caso de Londres. O setor privado, a oferta do setor privado vem aumentando. Enfim, de qualquer maneira, essa é uma questão posta exatamente, uma das razões pelas quais nós trouxemos a Adriana, para estimular a possibilidade de desenvolver, elaborar pesquisas que sejam colaborativas, né, com pesquisadores de lá, daqui e tal, a gente encontrar, seja para tese de doutorado, mestrado, pesquisador, professores, encontrar enfim, financiamento, mas elaborar projetos que a gente possa competir, buscar recursos para desenvolver. Essa é uma questão, né? Não sei se tem comentários. Eu tinha 2 ou 3 comentários que eu acho que são relevantes, e eu vou fazer em português, porque eu acho que importa muito para a gente. O comentário dela sobre a privacidade dos dados, a privacy, quer dizer, a segurança em relação ao tratamento dos dados. Como é que se acessa os dados? Como é que o dado é disponibilizado para o pesquisador, né? O que você tem que fazer para assegurar que esse dado não vaza, não se perde, não é enfim, hackeado, etc., né? Então, a gente tem, as experiências nossas são muito, nós temos poucas experiências na universidade com isso. Em geral, os dados a gente coloca no nosso computador, laptop ou mesmo no sistema, e nós não temos mecanismo de segurança adequado. E a lei de proteção aos dados recente nos impõe uma série de medidas, as quais eu, sem medo de errar, eu diria que praticamente nenhuma universidade oferece hoje, né? Tem uma experiência anterior na Organização Mundial de Saúde, e uma vez tentamos fazer um convênio com um centro americano que tem um repositório dos censos do mundo inteiro, né, em Minnesota. E eles nos disseram, não, depois o board lá examinar, a OMS não tem recorde, não tem nenhum caso de profissionais que tenham sido punidos, né, por deixarem os dados vazarem. E, efetivamente, esse é um problema importante, né? Então, nós estamos agora, o Fabiano, o Décio, o Jorge, o Fernando, eu e colegas da Faculdade de Enfermagem aqui, da UFMG, estamos trabalhando num projeto de análise do mercado de trabalho, demografia da enfermagem, e uma das questões postas na relação que nós temos com o Conselho Federal de Enfermagem foi de estabelecer mecanismos de proteção aos dados. Então, estamos fazendo um acordo e trabalhando com colegas do LNCC, o Laboratório Nacional de Computação Científica, porque nós não temos hoje condições de garantir que os dados não serão expostos, né? Então, esse acordo vai nos permitir utilizar a sala segura, os servidores seguros dele, vamos acessar os dados através desse mecanismo de VPN, sei lá quantos níveis de segurança, e estamos discutindo a instalação de uma sala segura aqui na UERJ, né? Para que a gente possa, enfim, progressivamente fazer isso. E entendimentos com o IPEA para fazer a mesma coisa. Tá? Então, essa é uma questão importante, às quais nós não nos atentamos tempos atrás e que hoje não temos como fugir disso, e que, no caso, por exemplo, acessar dados de pacientes, né? Que são dados sensíveis, ou dados mesmo do censo. O IBGE tem todo um processo de anonimização, mas isso não é a mesma coisa com outros dados. A segunda questão, que é uma coisa interessantíssima, por exemplo, que eu acho que a Rosângela trabalha com isso, a introdução de tecnologias, de medicamentos, de tratamento para doenças raras, né? O impacto que isso tem sobre o recurso do sistema de saúde, a judicialização aqui no Brasil, tá certo? Então, essa também é uma questão que pode ser de interesse mútuo, porque, enfim, os mecanismos são diferentes, né? E eu acho que o papel do Centro de Economia da Saúde, o CHE, da Universidade de York, é muito interessante, porque se definem como um centro, está dentro da universidade, mas se definem como um centro que busca produzir conhecimento, evidência, para os processos de direção de política pública em saúde, para os processos de discussão, para a agenda de debate, tanto para enfim, sei lá, o debate político no âmbito dos parlamentares, como no âmbito do próprio sistema de saúde, do NHS, né? Ela me contou, outro dia tivemos uma reunião online, antes dela vir para cá, então, no dia anterior tinha uma reunião com o Departamento de Tesouro lá para discutir a alocação de recursos a partir dos trabalhos que eles vêm fazendo. Então, acho que esse é um papel importante, eu disse isso na transmissão, né? Eu penso que nós estamos convencidos que o Instituto teve esse papel no passado, tem tido esse papel, talvez com não tanta ênfase quanto a gente pode oferecer. A gente produz aqui um conjunto de pesquisas, em colaboração ou não, né? A maioria delas, uma boa parte delas financiada com recursos públicos. Eu acho que a gente precisa ter esse papel, uma palavra que eu não gosto mesmo, é devolutiva, quer dizer, devolver e influir nos processos de decisão política. Acho que essa é uma experiência interessante deles, que a gente pode aprender com eles e trocar, né? E por fim, eu disse, ela ressaltou bem, né? Que pese diferenças, é muito importante, contexto, cultura, que isso faz a diferença entre os países, né? A gente tem a organização do sistema de saúde, das práticas da universidade, enfim, tem um peso na história. Por exemplo, o papel do médico aqui é diferente de outros lugares, o papel da enfermagem. Então, análises comparativas precisam levar em consideração isso, né? Há técnicas de você fazer, enfim, utilizar essas diferenças ou minimizar essas diferenças, seja do ponto de vista econômicas, culturais ou sociais, mas é importante considerá-las quando a gente faz estudos comparativos, mas não para não fazer os estudos, ao contrário, né? Para retirar desses estudos, né, o que seja importante, o que possa fazer diferença e impacto na política. Então, eu acho que aí a gente tem um campo muito interessante de trabalhar junto, né, elaborar. Se não tem ninguém tem assim, uma questão importante, eu queria deixar para a Adriana finalizar, comentários finais que quiser fazer, e dizer assim, durante esta semana nós vamos estar reunidos, o grupo de professores interessados, a partir de hoje à tarde já, com ela, tentando exatamente elaborar, enfim, um ou mais projetos de nos quais os pesquisadores aqui possam se envolver com ela, e o grupo ao qual ela lidera, e colegas do centro da Universidade de York, né? Mas abertos a, enfim, não sei se tem algum aluno que esteja interessado no desenvolvimento de sua tese de doutorado, né? Ou participando junto com o professor, com o orientador, né? Então, a gente temos desde hoje à tarde, amanhã o dia inteiro, né? De manhã e de tarde, temos temos que ter algum produto mesmo que preliminar para isso. Afinal de contas, recursos públicos estão sendo utilizados para esse desenvolvimento. Mas qualquer, enfim, de outras unidades da UERJ que estejam também tem interesse, a gente está aberto a isso e até gostaríamos de ter essa colaboração. Além disso, temos algumas outras atividades durante a semana que me pediram para reforçar, eu acho que corretamente, quer dizer, amanhã de tarde nós temos uma mesa redonda. De manhã temos eu não sei se o Washington vai poder fazer ou se vai ser o colega que vai o substituir. A gente estava conversando aí, ele tinha feito, me disse que tinha um backup para isso. E de tarde temos uma mesa redonda e o lançamento do livro da Liliádia sobre formação em saúde, um estudo que ela fez, foi a tese de doutorado dela. Isso é acho que um estímulo para os doutorandos, né? Mestrandos, obviamente, de publicarem seus resultados junto com os orientadores, com os demais professores que participam do projeto. Uma editora se interessou pelo tema, e é um tema, nós vamos ter aqui a presença da diretora de Gestão da Educação e Saúde do Ministério da Saúde, que é responsável por esse tipo de programa, por esses programas de residência, de outros programas aos quais o Ministério fomenta ou implementa, né? Enfim, então, à tarde. E logo após aqui, temos aqui um brunch, especialmente aqueles que vão continuar trabalhando aqui de tarde, com a Adriana, estão convidados aqui após aqui a fala dela. Adriana? Your final words?
Final words.
Or any comment?
Any comment? I noted down what you said about just now. I just one thing I wanted to say that perhaps is also important to know is that which is a big difference here to one of the things that needs to be noted, and I might be stepping on somebody's toes, but people in England who have private health insurance need to pay for the public NHS through the general taxation as well. Yeah, which is not the case in this country. So that is a big element that you may want to impress on policymakers on how you can improve, because that is a true two-tier system. That's all. Thank you.
Então é isso. Obrigado. Muito obrigado. Eu queria fazer um agradecimento especial aos tradutores que nos acompanharam nisso, né? E um pedido de desculpas para quem está assistindo pela internet. Estamos tentando experimentar um novo sistema, funcionou parcialmente, não funcionou, mas vamos aperfeiçoando isso. Obrigado. Cláudia, peraí. Depois deixa só onde para quem?
Na página de Saúde do Instagram, eu vou fazer um vídeo aqui. Aí eu vou postar também na página, né? E vai ter um canal da pós-graduação de saúde.
Tá.
E aí eu vou disponibilizar um vídeo dessa aula lá.
Tá, eu só queria algumas fotos dela para ela mandar para o pessoal dela lá na Inglaterra.
Eu vou botar tudo em drive, incluindo a posse de ontem e as de hoje. Eu vou daqui a pouco subir para corrigir as fotos e
Tá bom. Tá bom. Que aí ela manda lá para o pessoal dela, que o chefe dela lá também quer ver.
Não, sem problema.
Tá bom?
Eu vou fazer.
Obrigado.